Thank you, Gaurav, for the kind words. So I'll be just talking about I'll go back to the much basics of PCR. So what are the signs of PCR? I think everybody should know that sudden deepening of the antechamber with dilatation of the pupil and sudden transitory appearance of the clear red reflex in the peripherally, and also excessive tipping of one pole of the nucleus whenever there is a small red. So these are the few points I think we should remember whenever there is a sudden PCR when you're starting. So what should be the response? As soon as you see stop working means do not withdraw the phaco instrument, go to the foot position 1, maintain the chamber stability, do not allow to collapse, fill the antechamber with a dispersive viscoelastic through the side port, then withdraw the phaco tip, assess the situation, inspect, relax and think. So some of the few ways to to see for vitreous in the antechamber like spawn test, sweep test, halo test or stain test, I think everybody knows about that. So management again depends upon the surgeon's confidence, also the amount of nucleus remaining, the density of the nucleus, and also other accompanying factors like small pupil or loose zonules. So what should be our goal of the management? Avoid posterior dislocation of the nucleus, prevent damage to the endothelium, also prevent enlargement of the tear, prevent damage to the capsular axis, removal of the leftover cortex. Also, we should maintain a proper wound size and proper positioning of the intraocular lens. So, this is one of the video I have taken almost 15 years before this video I have taken from my friend Satyamurthy from Hubli. So, see, if you see here is a grade 4 cataract while operating, suddenly you could be able to see there is a small rent in the last part of this one. Again, you could be able to see the chopper is also sharp chopper that might have also touched the PC. In such cases, not to worry. So, always you can convert into posterior capsular axis as the previous speaker spoke. Then you can put the lens in the bag itself even without doing the optic capture depending upon the size of the posterior capsular rent. So, whenever there is a impending nucleus drop, whenever there is accidental PCR, do not try to chase the dissenting fragment. Then, of course, if you start irrigating in the vitreous, in the end the rent may become large, then later on you may have a giant retinal tear too. So, some of the technique which has been described by few of our friends, one is by Dr. Harbans Lal, this is called a chopstick technique, and the second one is posterior assisted levitation by Dr. Kelman. So, what we do in PAL technique, through pars plana incision, the viscote is injected behind the nucleus and the thin canal of viscote or iris repository used to push the nucleus forward. So, one of the technique which has been described by our dear Amar Agrawal, he is something described as IOL scaffolding, where whenever there is a rent, we have to put the IOL. Just I will show you the video. See, there is a rent. Then put the IOL in the sulcus. So, already there is nucleus. The surgeon is trying to get the nucleus above the intraocular lens. So, still struggling, not to become panic. In such cases, go with the 26 gauge needle, the pars plana, try to guide the nucleus above the IOL. Then you can do the phacoemulsification by protecting the endothelium with a high molecular weight viscoelastic. So, when you are doing a phacoemulsification, when you have to convert into a manual technique, that also you should know depending upon the type of cataract. See, here you can see this is a very jet black cataract, started the phaco, suddenly you can see sudden deepening of the antechamber. So, someone very good at in conventional cataract surgery, previously I think 30 years before, most of us started with this golden technique. Since the cataract is so black, I think here the converted into a ECC, then do a good vitrectomy, put the lens in the sulcus and you can put the suture. This other case, you can see while started the phaco, probably it might have be associated with the postopolar cataract. You can do the manual small incision cataract, extend around 7 mm. You can extend the capsular axis. This is very, very important. The sort of a railroad technique, you guide the nucleus into the anterior chamber, put a sufficient amount of viscoelastic in the antechamber, then those are very comfortable with the snare. I think you can divide nucleus into the two pieces and each piece can be removed. So this is very important. The decision what you take on the step is so important, so that good vitrectomy, then put the lens in the sulcus is very, very important. So of course, whenever to continue that, depending upon the bulk of the nucleus and the degree of the nucleus sclerosis. So I will not be talking about the technique, but normally whenever there is a rent, always I do with the bimanual irrigation. This is important. So here rent has been noticed, especially in the case of a post-polar cataract. You know that the chances of PCR is almost 100%. So in such cases, from the paracentesis, as I already told, visco has to be injected to the paracentesis. Then you can do something called a dry aspiration bimanual, so that the rent won't extend. Then you can straight away go ahead with the placement of the lens in the sulcus with a optic capture. That makes really sense. So of course, there are certain things I wanted to discuss, but because of the time factor, I will not be continue. What are the sittings for anterior segment? Always how exactly you have to do the vitrectomy when you're doing to the anterior segment. But this is the one technique I just wanted to show with you. This is a technique one of our friend Dr. Abhay Waswada said that whenever there is a PCR, whenever there is a rent to do vitrectomy, always he preferred to do through the pars plana. That gives much more better results. Also the amount of vitreous what you can take out through pars plana much better than if you approach through the anterior approach. So I think triamcinolone is injected in the AC, do the vitrectomy, make sure that you have done a proper vitrectomy, then you can go ahead. If it is this one, I think I will just take a 1 minute, Gaurav, I will just take 1 minute, then you can convert this into a posterior capsular X-ray. Can you continue just 1 minute? Okay. Yeah. So coming to the IOL implantation, sometimes if the rent is, you need not have to put IOL. Nowadays we put it in different techniques are available, like scleral fixated lens, IOL in the sulcus, or glued IOL. So I just wanted to show you. I think most have been we have to know this technique. One of the technique I think most of been India has been practiced, that is iris claw lens. So whenever there is rent, I think nowadays we stopped doing scleral fixated IOL unless and until there is a lot of damage to the iris. Rather, I think these iris claw lens give very good results. After doing a proper vitrectomy, I think go with the claw lens, then tuck it under the iris. I think something everybody should learn this, so that there is something called a life-saving technique whenever there is a major serious complications. So finally, vitrectomy is very, very important, and also you should do iridectomy and suture the wound, and you can remove the suture at the end of the 15 days. So of course, you can last slide, and he can, if it is there, I think you should refer to the vitrectomy. So in conclusion, the incidence of posterocapsular rent can be significantly decreased by identifying the presence of predisposing factors and appropriate modification of the surgical plan. Early recognition and treatment of capsular tear and the vitreous loss, that helps to prevent the serious complication and improve postoperative outcome. Complications do happen in the best of the hands, but true competence of a surgeon is judged by how he handles the complication. Thank you.